acute exacerbation of chronic obstructive pulmonary disease. 2.4.1 Oral Presentation. What is chronic obstructive pulmonary disease, COPD, and how does it relate to acute exacerbation of chronic obstructive pulmonary disease? Is COPD a chronic lung condition? Yes, it is a chronic and progressive lung condition with irreversible obstruction and inflammation of the airways and lungs. It includes chronic asthma, chronic bronchitis, emphysema, and bronchostasis, as these all have persistent airway limitations, inflammation, destruction of alveoli tissue, and loss of elastic recoil. AE-COPD is a flare-up or acute exacerbation of COPD. My presentation will cover one high-priority clinical manifestation of AE-COPD, being hypoxia, using the A to G assessment via an ISBAR handover. Hi, my name is Evelyn and I am an enrolled nurse on shift this evening in ED. I'll give you a handover before I finish up my shift today. Marjorie McDonald was admitted under the respiratory team. Marjorie went to her local GP as she had an increase in dyspnea, a productive cough, and she was febrile for 7 days. Marjorie is a lovely 74-year-old lady with a 5-year history of COPD. I started to do her A to G assessment and had to stop at B/C. Her airway was patent, she could talk and respond. However, she had severe dyspnea, a respiratory rate of 32 breaths per minute, and when I checked her pulse, she was tachycardic at 130 beats per minute. As I placed the pulse oximeter onto her finger, I observed cyanosis around her lips. Her saturation came back 86%, which in conjunction with her increased respiratory rate, heart rate, and cyanosis confirmed to me she was hypoxic. So I commenced 2 litres of supplemental oxygen via nasal prongs and initiated a clinical review as her vital signs improved out of the red and into the yellow zone. The clinical manifestations of hypoxia is very important as this is a medical emergency. All living cells require oxygen to survive. Hypoxia is a deficit of oxygen in the cells and tissues of the body. The consequences of not recognizing the clinical manifestation, and if left untreated, can lead to hypercapnia. This is retention of carbon dioxide in the lungs. As COPD progresses, ventilation is impaired. The inspiration, inhalation, and expiration, exhalation enable the exchange of oxygen and carbon dioxide. As these are both impaired, if left untreated, the dire consequences are further deterioration and death. I will discuss the pathogenesis of hypoxia within the context of AE-COPD, using the case study of Marjorie McDonald. Whilst at home, Marjorie had a flare-up of her COPD, which had increased her dyspnea, cough, and sputum. This acute onset had led her to be admitted to hospital. During this exacerbation of COPD, a trigger, such as a virus, bacteria, or air pollutant, irritated an inflammatory response within Marjorie's respiratory system. The response caused neutrophils, eosinophils, and macrophages that impact airway inflammation and lung damage, including alveolar damage and loss of elastic recoil of the bronchi. The functional impairment leads to increased bronchial tone and narrowing of the airway. Alveoli destruction from the inflammation allows large air spaces in the lung tissues and pleura, therefore reducing the area for gas exchange as ineffective. This alveolar and respiratory tissue damage, in which gases exchange across the air and blood, causes a serious ventilation-perfusion mismatch, resulting in hypoxia. This mismatch results from ventilation, airflow, or perfusion, blood flow, being impaired and unable to deliver oxygen to the blood, resulting in hypoxia. Marjorie had symptoms of this mismatch with severe dyspnea, tachycardia, and cyanosis. The chemoreceptors located in the aortic arch and carotid usually respond to changes in oxygen and carbon dioxide levels in the blood. However, as Marjorie has COPD, these essential chemoreceptors become less sensitive to respond and impair the ventilation. Marjorie's heart rate has increased to try and compensate for the increase in respiration, and cyanosis was visible in the blue tinge around her mouth, having low oxygen saturation. In conclusion, I will identify one high-priority intervention of supplemental oxygen therapy using the case study of Marjorie McDonald. As Marjorie's saturation was 86% on room air, this is too low to sustain an adequate supply of oxygen to her body tissues. It is in the red zone on the SAGO chart. And in combination with other clinical signs of distress being dyspnea, tachypnea, tachycardia, and cyanosis, the use of oxygen was a medical emergency to stop her acute deterioration. I administered 2 litres of oxygen via nasal prongs, and after a few minutes, her saturation came back up to 94%. This is a result of the oxygen supply entering the lungs and oxygenation of the red blood cells carrying oxygen throughout the body system. Her other vital signs of concern came down to the yellow zone due to oxygen being administered and reversing the signs of hypoxia. I initiated a clinical review as she remained in the yellow zone, and I needed her reviewed to prevent further deterioration. In Australia, supplemental oxygen is an unscheduled substance, so there is no legal requirement that must be prescribed by a medical officer. Thank you for your time, and goodbye.